It's now being confirmed that fewer people contracted HIV/AIDS around the world last year than in any of the years since the 1980s. In other words, there's finally evidence that we may be able to control the prevalence and the spread of HIV. Dr. Roger Phili is the Executive Manager for Operations at the South African National AIDS Council. Dr. Phili, good afternoon to you. I mean, this is good news for the world, but in South Africa specifically, how is the number of HIV cases, the new cases in our country, changing?
Now, good evening, good afternoon, Stephen, and the listeners. Yes, I suppose you are referring to the UNAIDS report that was also released at this conference here in Germany. Yes, the situation is still dire in our country. About 25% of all infections worldwide still happens in South Africa. However, the country's progress in combating HIV has been noted. We already have a 77% coverage in terms of ARV treatment that was reported under that UNAIDS report. There's still work to be done to move the country to 95% of people living with HIV undergoing ARV treatment, which is the goal that we are trying to reach even before the period of 2030, where there is a desire to eliminate HIV and TB as public health threats by then. So it's promising, but there is still a problem. There is an estimated 1.7 million people in the country that are HIV positive, but still not accessing ARV treatment. But overall, the progress the country that it has made so far has been well noted here.
Do you think we'll ever be, I mean, it's important to mark that progress, but do you think we'll ever be able to bring down significantly the number of new cases of HIV? In other words, are we going to be able to stop our people from still contracting HIV?
Yes, that report also says that as long as the resources that are required to combat HIV and TB are not reduced, it is still possible to have HIV and TB controlled by the year 2030. We just need to ensure that the momentum that has been done is not lost. So in this conference, Stephen, also, because it's not just a matter of making resources available, it's also to ensure that we have a prudent use of those resources and we are able to adapt to new strategies as are appearing at this conference. Prevention remains the cornerstone of the response because prevention is much cheaper than to treat and care for the people that are infected by the virus. Hence, here we are learning of even newer strategies that we can use in the country to change the trajectory, as you are saying. So, for example, just yesterday, even from our own researcher in South Africa, a report was released on the new drugs which are called long-term acting ARVs that can be injected. It's twice-a-year injection that was released by Professor Linda Gale-Becker's team from Desmond Tutu Foundation. And it shows just if you can implement that intervention on its own, it can heavily address the problem because some patients are unable to adhere to daily doses of medication that is required. Hence, then, if you can have a long-term injection like that, it can eliminate a lot of pressures, even financial burden for people to be coming all the time to the clinics. There is also some promising research that we have seen that provides opportunities for long-term prevention. We do have in the country a program that is called PrEP or post-exposure prophylaxis and pre-exposure prophylaxis that are being used, but they are requiring that especially the high-risk populations take these tablets on a daily basis. But from the information we are getting here is that there are long-term ARVs that are now coming online that will make that kind of treatment much easier and also put it in the control of those groups, especially young girls and women. We know that currently the most effective form of prevention is to use a condom, but that is entirely up to the men to use it. So if we introduce interventions like this, then we're putting power back to the women to be able to control the HIV spread, which currently severely afflict young girls and women. So it is possible if we are able to be innovative and adopt all of these lessons that we learn out of conferences like this.
Dr. Phili, you talk about government's efforts in antiretroviral drugs and the progress that's been made there, and it's very important. To what extent are we actually still dependent on PEPFAR, which is an American program? In other words, a lot of this, if I remember correctly, is being funded by the United States government. The reason I ask is the United States government has shown signs of, well, that things could change. Let me put it like that, Dr. Phili. Are we still dependent on American money? Do we need to try and make ourselves independent of that?
Actually, Stephen, our case as South Africa is quite different. Most funding for HIV and TB response still comes from the government. It comes from the government coffers. 70% of the funding required, even for this NSP term that is up to 2028, is still expected to come from the South African government. Of course, there is that gap of 30% of funding that is required, and a bulk of that is funded by PEPFAR in terms of the HIV response. So that is correct. So PEPFAR is by far a single largest contributor after the government of South Africa. But the good thing is that at least for the mid-term, they haven't reduced the funding for the country. Actually, the allocation for the country operational plan of this year and next year is still flat for PEPFAR. But as you are saying, there is dwindling external resources that are being poured into the response. So we hope that PEPFAR will continue to fund the response. The Global Fund also is another donor after PEPFAR that also contributes. And then the rest of the funding comes from the private payments that the people pay when they go to see general practitioners and so on. So yes, PEPFAR is by far very important. It's estimated that roughly in a year, they spend an amount of about $405 million in terms of the response. So hopefully, and all indications are that there is still commitment from PEPFAR because it is critical that they maintain the response. But the role played by the South African government, we cannot undermine it. It's actually significant. Actually, it's one of the very few countries in sub-Saharan Africa where the government still funds the response to the extent that it does.
And Dr. Phili, a scientific question, a medical question, if I may. You say we have around 77% of our people who are HIV positive on antiretroviral drugs. If we get it up to 90, 99%, 100%, hopefully, of people who are living with HIV on antiretroviral drugs, does that have any impact on the spread of the disease? What I'm trying to get to is, if you take ARVs, does it make the HIV that you have less contagious, or does it have no impact at all?
Certainly, Stephen, you know that in terms of the strategy, the UNAIDS has set it up at 95, 95, 95, which means that it's 95% of people who are living with HIV needs to know their status. And then out of those, 95% needs to be on ARV treatment. And then 95% needs to have a viral suppression, because that is the key thing. They need to take the medication as prescribed and at the times that are indicated and correctly. So if there is viral suppression, there is scientific evidence that the transmission of the virus is not there or is very reduced. So that is why treatment itself is a form of prevention. Hence, the more people you get onto treatment and those people are virally suppressed, then you are likely to turn the situation around. So that will be absolutely correct, what you are indicating, Stephen. If you can move it up to 99%, that will be absolutely great. And it will definitely turn the tide in terms of new infections.
Dr. Roger Phili, thank you. Executive Manager for Operations at the South African National AIDS Council.